I'm going to introduce my coach, Dr. Essam Elgamal. He's a consultant neurosurgeon in Abu Dhabi in United Arab Emirates. I have known him for a long time. He had been in Bristol. He had trained in Bristol as well, and he has been in the listserv ever since, and I have enjoyed his comments in the listserv. Dr. Elgamal, may I please ask you to chair the next two talks, please? Thank you.
Oh, thank you, Naren. Thank you very much. Yeah, if Dr. Prasad is ready, we can have his presentation shared with us.
Thank you, Dr. Elgamal. Thanks, Naren. Thanks for this making this wonderful webinar happen, because this is a topic which is generally not focused upon, and as we are seeing, it definitely requires an exclusive time. So to continue the same thought process I am taking to, like, as we are seeing, there is limited ways in which we can help our patients with our limited understanding. As we delve more deeper and deeper, we are realizing how little we know. And as we clinicians, as it is repeatedly brought out, we need to take decisions, yes or no. And this is something which occurred to me recently, that there is another side of the spectrum about the hypotension, intracranial hypotension, which has its own spectrum of presentations. And there are some aspects of it, some presentations of it, which are eminently treatable with good results. Particularly recently, when Naren introduced me to this webinar we were discussing, I was in New Delhi in a spine conference. My area of interest is in CV junction. And in this meeting, there was an young neurosurgeon from Queen Square Hospital who presented, I forgot his name, about their work on selected subset of patients of Chiari malformation, in whom there was a defect in spinal dural defect which was noted, and when they identified and plugged it, so they could reverse the Chiari malformation. So that was a new thing for me. Probably it was there, but it was new for me. And that took me further into exploring about intracranial hypotension. What is spontaneous intracranial hypotension? It's a kind of a new clinical entity which some of us know because we are exposed to it, but some of us are not much aware of it. So my message in this small presentation is to make that awareness happen in our day-to-day practice as neurosurgeons, that some of the subset of patients who will present with headache, who does not fit into any other categories, which is not neurosurgical, not neurological, may be the case of intracranial hypotension. The cause of this would be generally believed to be spontaneous spinal CSF leak. And the classic presentation will be positional headache, orthostatic headache. So the onset can be abrupt or it can be gradual. It may take up to 15 to 30 minutes for onset. And when they sit up, they develop this and they become recumbent. Over a period of time, maybe half an hour, 1 hour, 2 hours, the headache totally resolves. So this is something which, unless we keep a special note of that, we may miss when the patient is giving the history. Some may be minimally affected, but some I have seen have profoundly disabled because of this severe headache. And they keep repeatedly telling about the orthostatic reference, but unless we are aware of this entity, we may miss it out. So, and they will be fitting into the typical patient of fibromyalgia or any other non-specific back pain, neck pain, or some kind of myalgia, which we may pass it off as fibromyalgia. So we have to be aware of this kind of patients who would present with occipital headache, nuchal headache, or it can be generalized frontal headache also, particularly told as a pulling kind of sensation. They may also present with many other features. And curiously, in a recent meta-analysis, it was also found that headache per se need not be a presenting symptom. There are other symptoms which can be present, like as we see in this analysis. Orthostatic headache is the most common thing. Nausea, vomiting, neck pain, Ear-related symptoms, headache, giddiness, tinnitus, vertigo, photophobia, phonophobia, cognitive disturbances, including like Parkinsonism kind of picture. This is also described. So generally, so the consensus, the thought is that it is half as frequent as subarachnoid hemorrhage. But do we see so many cases? Do we recognize them in our day-to-day practice is a big question. We grossly underestimate the amount of burden which is there in the society of something which is potentially treatable. So that awareness as we sit in the clinic and when we see the patient with this kind of profile is something which we need to stress upon and not to forget. So International Classification of Headache Disorders, ICHD-3, takes this criteria for diagnosis, that is low CSF pressure, less than 60 millimeter of CSF, evidence of CSF leakage on imaging, headache which develops in temporal relation to low CSF pressure, and in the absence of procedural trauma as cause of CSF leakage. As surgeons, we are all aware of that low pressure headache, particularly when we do lumbar punctures. Few days later, soon after, people develop this kind of low pressure headache, which stays for some time, and we know how to manage bed rest, fluids, and we reassure them that it gets better over time, which normally will. So, and some of the pseudomeningocele which develop after some CSF leak, which develops after a spinal surgery. So, but by definition for this spontaneous intracranial hypotension, so these should be excluded. So these are not included in the definition. And the temporal relation to low pressure as well as development of symptoms is something which is the other feature. Whereas the other two, evidence of CSF leakage on imaging is not a mandatory thing required because many times, depending on the resolution of the imaging, we may not see that leakage. And it's curious to know that low CSF pressure is also not an essential requirement for these cases where CSF leak is present and which may make the person symptomatic. Though 3/4 of them would have low CSF pressure, there are a subset of people who will have normal pressure and a very small subset who will also have high pressure. As we just had a question about small kids who have raised ICP but with normal cognitive function, we don't know why they have high pressure but still have this dural leak and develop symptoms. So this is the traditional classification types of what causes the leak in the dura, spinal dura. And when we are recumbent, this 90 to 150 ml of CSF in our system is distributed 1/3 in the brain and 2/3 in the spinal column. We know that. And the 0 point you can consider when we stand up will become at the level C7 to D5 approximately, where we can take it as 0. Above that, it will be negative. The pressure can be considered negative, and the pressure below is considered positive. And because of the erect posture, there will be some shift in pressure which happens, which is compensated by physiological means. That reduction in intracranial pressure due to little drop in volume into the spine is compensated by physiological means. But if there is an ongoing leak in the spinal dura, through the spinal dura, then that's when the symptoms start developing, that sagging feeling will develop. So the type 1 of the leak is considered the dural tear. And there are again two types, type 1A and 1B. These are generally due to osteophytes, which will rub into the dura and thought to be cause of that CSF tear in the dura, in the dural tear. And the ventral tear is considered type 1A, and posterolateral tear is considered type 1B. And type 2 are because of meningeal diverticula, which can be simple or complex dural ectasias, which are by the side, as you see in this diagram taken from Barr's article. Type 3 is a CSF venous fistula. These are rare ones, but they are found recently. Recently meaning it may be some 15-20 years. The reports are there from that time. It's a curious entity, but a real entity which really trouble people, which the CSF venous fistulas, which can be treated with embolization too. And type 4 is an indeterminate origin. One, because our MRI may not be sufficient enough, or CT myelogram, which is much more sensitive, may not be sensitive enough to recognize those small leaks. Or maybe it is just that the compliance of the spinal system is more and it is accommodating more. It has become a dilated bag and it just accommodates more fluid. So that's the theory which is put forward in this new paper, which spontaneous intracranial hypotension without CSF leakage, concept of a pathological cranial to spinal fluid shift. This is a new theory which is put forward, that even though there is no tear in the dura, even though there is no diverticulum, it's just that increased compliance in the spinal level is causing that sudden shift and make the patient symptomatic. So what to do in such patients? Like, now we know and we are aware of this entity. So the next step will be to keep an eye when we see the MRI to those subtle findings which may point towards intracranial hypotension, which we are generally not particular about. So the mnemonic which is made for this is SIEVS, S for subdural fluid collections, which occur in about 1/3 of patients. And pachymeningeal enhancement of the meninges is that P, which is much more common, about 3/4 of the patients will have. And engorgement of venous sinuses is the other thing. And pituitary hyperemia and sagging of the brain, which will lead to that reduced pontomammillary distance and flattening of the ventral part of the pons, as we are seeing here, crowding at the foramen magnum, tonsillar descent, and as I just explained, kind of acquired Chiari. So this is also the MRI finding which we need to keep in mind. And in further, we are also seeing in the spine, in the spinal imaging, we can see a longitudinal ventral fluid column. Spinal longitudinal collection ventrally to the ventral to the dura is something which is classically described. I take this example of this 39-year-old lady who presented with intermittent headache with blurred vision since 4 years. She had a typical postural relation to her headache, and neck pain worsened in the last 1 month. MRI showed this spinal longitudinal epidural collection, as we can see, and there were no further evidence of any definitive CSF leak appreciated on a CT myelogram. So what are the treatment options in such cases? Conservative management, as we do for those cases after spinal surgery or lumbar puncture. The most important thing, which is new for us neurosurgeons, which is not commonly practiced, is epidural blood patch, which has excellent results. Surgery also has a role, I will explain that. And embolization of CSF venous fistula is a novel form for the subset of patients. Conservative pain management is the same symptomatic treatment for pain as for spinal post-operative spinal leaks. Bed rest, good hydration, caffeine. 28% improve or resolve, as stated in that meta-analysis of over 1,700 patients by, again, this Queen's Fair group. So they say like at least 1/4 of them improve with conservative management. But once you recognize that, being surgeons, like, it is not wise, and that's the time when we think about planning an epidural blood patch, when we think about treating it in a confirmatory way by using an epidural blood patch. There are two kinds of blood patch which can be used: autologous blood, which can be placed epidurally, non-targeted epidural blood patches, or targeted patch when we identify the site of leak. Non-targeted lumbar epidural blood patch will seep all along the epidural space and go up to the area where this leak would have potentially happened. And immediate relief will be noted not just because of the plugging immediately, it's because of the mass effect, the tamponading which will happen. And the volume of the autologous blood is around 20 ml generally. And sometimes some centers use a higher volume up to 40 ml. And this meta-analysis has found that those people who have used larger volume, the outcome is better. And if it is not working with the first injection, then second blood patch can be repeated after a few weeks. Targeted patching is again with once we note a particular site with CT myelogram, we can use same autologous blood in that particular location, or even fibrin glue can be used there. And surgery has limited role, particularly when we see meningeal diverticula, we can ligate it, clip it, or put a muscle project with fibrin. And if there's a CSF venous fistula, again, we can ligate, clip it, or use a transvenous embolization of CSF venous fistula. Repair of dural tears can be attempted in selected cases where there's a ventral or posterolateral herniation. And it's, I am remembered of those cases of ventral called herniation, where many times we leave the ventral dura open, try to attempt if it is possible to close it, but some cases I leave it open because it's too inaccessible to put switches there. Not many of them would develop this kind of. So there is something which is unexplained and unknown here, where that intentional opening would not cause symptoms, whereas unintentional and the natural process of an osteophyte rubbing into and causing a dural tear would make a patient symptomatic. So generally in our center, this epidural blood patch is done by our anesthetist. And this is the procedure. I just want to show a small video here. So first step is to reach the epidural space, which anesthetists are quite familiar with. The way to recognize the epidural space is quite important by checking the pressure there, and the sudden give way of pressure will identify the time when slowly the needle is pushed in, and we can see a sudden pop, and that's when the epidural space is reached. Simple procedure only that we are not used to. Anesthetists are regularly used to this procedure, so yeah, so that's it. And then an autologous sample of blood is taken, and 10 ml is taken one at a time. And he is asking about any tachycardia, any numbness in the lungs as the blood is injected, any paresthesias. He's just feeling some pain in the site of injection and nothing else. So good to proceed. Slowly it's injected, and again a second helicopter is taken. Another 10 ml is taken and injected.
But I can't pull out the catheter share.
Simple procedure which has an excellent result and immediate relief in up to 2/3 of the patients. So with this, the objective of my presentation today is to bring our attention to something which is grossly under-recognized in our general neurosurgical practice, which has a potential treatment available. Only we need to be open in watching for those characteristic clinical findings and MRI findings. And when the patient complains of orthostatic headache, keep this spontaneous intracranial hypotension in mind as a potential treatable cause for headaches. Thank you very much.
Thank you very much. Thank you, Dr. Prasad, for a very nice presentation. Is there any question from the audience, please? If no, I can ask you actually.
Yes.
Our problem is with the patient who have this non-targeted epidural blood patch, and they come back with recurrence of symptoms. And they hear about the off-label intrathecal injection of gadolinium for the proper diagnosis. So do you recommend this, or still not yet recommended?
I didn't get it. Intrathecal something?
Gadolinium for MRI scan to just try to spot out where this CSF is leaking from.
Yeah. So in by what I see, though as a neurosurgeon, and I am tempted to do that before I advise a epidural blood patch with non-targeted. the evidence and this extensive meta-analysis suggests that when you suspect it clinically, that's a good time to consider non-targeted epidural blood patch. For the very reason what you said, that the very hole what you make for this gadolinium may cause leak again. So, but in those cases in which we need a diagnosis, CT myelogram is more preferred than MR myelogram with the available machines in our place. And that we have seen, which shows this diverticula or sites of leak.
Okay, thank you. Can see a hand raised, Dr. Badashai, please.
Yep. Thank you very much. So if I could just ask you a question. Thanks, Komal. That was a fantastic talk. I agree with you. You know, we underappreciate, become so obsessed with raised pressure that we forget about intracranial hypotension, particularly like you say in the context of tonsillar herniation. I want to ask you a slightly biased question. You know, we spend a lot of time with non-invasive markers for raised ICP, you know, like the nerve sheath diameter, cranial deformation, pupillometry, those sorts of things. Are there any markers or techniques, non-invasively like that we can use similarly for intracranial hypotension that you're aware of?
Yeah, I mentioned about that mnemonic with MRI that would help us in our clinic, like that that sagging of the brain, pachymeningeal enhancement, engorged veins, pituitary hyperemia, and that subdural fluid collection, reduced pontomammillary distance, flattening of the ventral pons. So these are the things. There are no metrics for that, but those are certain clues to suggest that there's something going on about reduced pressure.
Okay, Naren seems has a question. Go ahead, Naren, please.
Before I go ahead, is it okay if I ask Dr. Jallo and Dr. Casares whether they have any comments and questions?
Sure. No, thanks, Naren. Dr. Prasad, that was an excellent presentation. I mean, fortunately, I've seen it in very few patients. The question I had is there a concern using the large volume of 40 mLs in the epidural space and causing mass effect and neurological deficit in that population that you do the non-targeted procedure for?
Yeah, curiously, no. My insight about that is only through the meta-analysis. Whatever we have used is less than that. But there are two take-home messages in that large meta-analysis, which is in JAMA Neurology in 2021. One was about the difference between the outcome in the volumes, the lesser volume and the larger volume, which suggests that the larger volume had better outcome. And the second one was this atypical presentation where there is no reduced pressure, no typical MRI findings. They by themselves per se will not exclude a diagnosis of this condition, which would benefit from a epidural blood patch. So going by that, I mentioned about that larger volume, but even I am concerned that 40 ml may be a little too much. I won't be doing it in first place.
Yeah, I agree. 40 mLs looks too much, actually. Is there any other questions?
Adrian, do you have any question, Adrian? Okay.
I would just like to add that we have done MRI studies in children using off-label gadolinium. We use 5 cc's of gadolinium. I'm not going to say we do it very often, but up until now, at least in, I would say 10 to 20 cases, we have never found any, serious side effects. So I think this is something that probably should be more, we should pull data in what happens in both adults and children.
Great, thank you.
Thank you. Can I ask my questions or more comments than questions? Is that okay, Essam?
Yes, please.
Thanks. When I started in neurosurgery in Southampton, we had a patient who had a burr evacuation for chronic subdural, and his GCS didn't really come up. Had another burr evacuation to re-evacuate what was left, and his GCS went around to about 7, 8, and he was like that for about two days or something like that, and we couldn't quite figure out what was happening. We thought the patient was pulling a psychosomatic. Got the neurologist, they came and did all sorts of tests, putting the hand over his face, that and this and everything. Then I can't quite remember the sequence of the events. Then we went and had a chat with the radiologist. And as we were walking out, the radiologist said, well, it looks like there's a dural enhancement on the scan. And so we got the anesthetist to do a patch. And it was like magic, in the afternoon, he was GCS 15, and next day he went home. And, which was very instructive to me. So whenever I am on call and my registrars bring any sort of chronic subdural, so my job is not, I'm sure they are able to manage chronic subdural, but my main thing is to make sure that we are not missing a patient with intracranial hypotension and has a subdural from that. I have seen subsequently when I became consultant and worked in other places, the patients with at least 2 patients who had complicated course of chronic subdural with multiple operations, looking retrospectively, they were intracranial hypotension. And about 6 months ago, I had a lady come in. She had been on warfarin. I can't quite remember what the cause of it was. She had a cough, and then she had bilateral subdural. Once again, there was some acute and chronic. It took a while for her to present to us. And for some reason, I had that suspicion that this was, whenever I see bilateral chronic subdural, I'm always a bit anxious. And so then spoke to the radiologist, and they could see some brain sagging. And then we did MRI scan, a high resolution MRI scan. It's amazing how you can see all the arachnoid blebs on the nerve roots. And she then had a blood patch, and she once again improved dramatically. The only thing is that then she got a headache later on, a low-grade headache. And when I sent her to fundoscopy, they were suggesting that she has got possible early papilledema. So then obviously I moved from that place, and my colleague took over. And once again, as Komal mentioned earlier, I don't know whether she initially had the subdural because of cough upon having warfarin, but whether she had CSF leak because she had high pressure, and then the leak made her low pressure, and then our patch made her back to high pressure. So I think even with a humble chronic subdural, probably there's something to think about. Thanks.
Yes, Naren, you reminded me of a case which I wanted to squeeze in my presentation, which I didn't because it's a separate, looks like a separate entity, a chronic subdural, which was curiously in a very senior neurology professor we had. He himself was a very eminent neurologist, very witty, a very good teacher who is now in private elsewhere. He had a chronic subdural, and we evacuated it. It recurred, and that's when I'm not remembering the sequence, but we did a epidural blood patch. And I remember it was done in the cervicothoracic region also, C7D1. And it resolved like magic, as you said, like it never came again, and his symptoms totally resolved. So these are the cases. Maybe these days we would have considered middle meningeal artery embolization in such cases. This was maybe 6 to 8 years ago, when it was not known about middle meningeal artery embolization, and that was the only option we had, and that was kind of out of the box, and it worked magic. And I vividly remember that episode because he is our colleague neurologist and a very senior man, and it was really dramatic.
You, Essam. You are mute, Essam.
Oh, sorry. Thank you very much. If there is no more comment, shall we proceed for the next presentation?
Thank you.